Let's talk about trigeminal neuralgia. So the trigeminal nerve provides sensory innervation to the face through three major divisions: the ophthalmic, or V1, the maxillary, or V2, and the mandibular, or V3 division. The most common cause of trigeminal neuralgia is thought to be compression of the nerve root by a vascular structure. However, there are other causes, such as multiple sclerosis or brainstem tumors, and when those cause the symptoms, it's known as secondary trigeminal neuralgia. In the end, though, 10% of cases are still idiopathic. Trigeminal neuralgia happens slightly more often in women, and there's also an increasing incidence with age, with most cases beginning after age 50 years. However, this is not a hard and fast rule. So some anatomy. The ophthalmic division supplies sensory innervation to the forehead, the eyelid, and top of the nose. The maxillary division from the bottom eyelid to the top lip, and the mandibular division supplies sensation to mostly the jaw and the ear. For clinical features, the hallmark of trigeminal neuralgia is recurrent paroxysmal pain in one or more divisions of the trigeminal nerve. It can happen up to 50 times a day. However, it rarely affects V1 alone, so this is unlike post-herpetic neuralgia, which you may have to differentiate from this disease. When assessing facial pain, how long the pain lasts is very important in terms of making the final diagnosis. So for trigeminal neuralgia, there's typically severe pain that lasts anywhere from a fraction of a second to up to 2 minutes. There can be a refractory period before the next neuralgic pain can occur, and usually the pain does not occur in sleep. It is unilateral pain, and it can be sharp and stabbing, electric, or shooting pain. The pain can be precipitated by triggers such as light touch, cold air, chewing, and brushing teeth. There can often be mild autonomic symptoms such as lacrimation or rhinorrhea. However, if you have a lot of autonomic symptoms, you may think more about the trigeminal autonomic cephalalgias, such as Sunkt and Suna. So for evaluation, you'll want to look for a secondary cause which may be treatable, such as multiple sclerosis or a tumor, and you can look at that with a MRI brain with contrast, and a time-of-flight MRA head can also be done to look for vascular loops that may be compressing the trigeminal nerve. For treatment, medications are highly effective for symptom relief. The first line medication is carbamazepine. It can have side effects though, such as nausea, hyponatremia, rash, leukopenia, pancreatitis, and hypogammaglobulinemia. Oxcarbazepine can also be considered as a first line, especially because it has decreased drug interactions compared to carbamazepine, but also it has side effects that are fairly similar, such as nausea, hyponatremia, dizziness, and rash. One thing to note for both carbamazepine and oxcarbazepine is that they should not be prescribed for people with a specific allele, the HLA-B15O2 allele, and that is due to the risk of Stevens-Johnson syndrome, or TEN. Asian people are at risk and should be screened for this allele. In cases where medical treatment fails, you can consider surgical treatment, such as microvascular decompression being probably one of the most common ones. For prognosis, the paroxysmal attacks of trigeminal neuralgia can often last weeks or months, but there can also be pain-free intervals of months to years. After a few months, medical treatment can be tapered, but there is a high likelihood of pain recurrence after tapering medications.